Good morning, and thank you for the invitation. Can people hear me? Can you hear me now? Good. So we're going to be discussing the topic of fatigue or being tired in Parkinson's disease. And I can certainly tell you that my presentation is not going to be nearly as high-tech as Dr. Jog's. The most technology you're going to see is a PowerPoint presentation if this thing works. So let's see. Are my slides showing? Good, okay. So Parkinson's, as I'm sure you all know, has been with us for a long, long time. Dr. James Parkinson, a general practitioner in England in the 1800s, is generally credited with giving the first clinical description. And really, if you look at what he did, he really did an excellent job of describing the movement problems that occur. So he describes the change in posture, the slowness of walking, the tendency to shuffle, the tremor, the trouble initiating movement, the slowness and paucity of movement. He doesn't refer to people being tired, and indeed, it's quite a long time later before we actually hear about fatigue occurring in Parkinson's. So why is that? Well, as you can see, there it wasn't until 1967. Gosh, that's more than 100 years later. Why is that? Well, partly it's because it's hard to define the thing. And it's also probably an offshoot of our experience as physicians when we're training. So when we start out, when we see a new patient, we talk to them about the symptoms they've been having. We try to elicit the history. And you learn pretty quickly that if you ask, is tiredness part of your problem? It doesn't really help you a whole lot because 80% or more of people will say, yes, I sure am. In fact, if they were talking to me today, I'd say the same thing. I'm getting over a bit of a cold. I'm fine now. I stayed up a little later than usual watching the American election. Okay, so there's lots of reasons that people can be tired. That really doesn't do justice to the fatigue that occurs in diseases like Parkinson's, where it can really be an overwhelming problem. Another problem with kind of trying to study this is the difficulty in defining it. So just what do we mean? We mean more than everyday kind of tiredness. Some of the definitions that I came across, a lack of energy, a sense of tiredness and exhaustion, often both physical and mental. I think the mental part of it often gets short shrift. Both a physical and mental tiredness, a lack of energy, a total body give out, an inability to sustain muscle activity, that can really be profound as well. And that aspect of fatigue, as we'll go over a little later, is probably the part that's been studied the most. There's generally an agreement that it's more than just excessive sleepiness, but being sleepier than usual can certainly contribute as well. Now, when we come to studying fatigue, we find that most of the work has been done in the peripheral nervous system. So I'm not going to give you a whole lot of anatomical terms, but the peripheral nervous system is the peripheral nerves running from the spinal cord to the skin and the muscle, and the muscles that they innervate, and that's how we actually move. The central nervous system, or CNS, is the spinal cord and the brain. That's where most of the action is in Parkinson's. The reason the peripheral nervous system is studied is it's closer. It's easier to get at. And most of the work has been done in people who are basically normal, but there is also some work in people who have diseases of the peripheral nervous system. So, what do these things show us? Well, first of all, they find that when people are given a task, say for example, a slacker like me, you give me some weights and say, I want you to lift this barbell until you simply can't do it any longer. Start out doing just fine, unless it's too heavy. After a while, the movements get a little slower, they're more effortful. I'm perceiving, gee, this is getting tough. After a while, I can barely get it there. My muscles start to hurt, and eventually you hit a point you simply can't make the movement. And it takes quite a while to recover from it. And chances are the next day, I'm going to feel it, I'm going to ache. Well, that's part of normal fatigue. And we know a fair amount about what happens in that situation. So we know that The oxidative enzymes that enable our muscles to use oxygen, those things are depleted. Compounds or chemicals that store energy in the muscles, things like ATP and creatine kinase or CK, those things fade off. There's a buildup of acidity, lactic acid in particular builds up in the muscle. And all of this creates the difficulty in sustaining that muscle contraction, the effort you perceive, the pain that you eventually develop. Now, as your muscle's starting to fade out, our brain is saying, hey, this isn't what we intended. You're still supposed to be lifting that barbell. So we produce more nerve activity to try to get that poor failing muscle to keep doing it. And one of the things that we think underlies fatigue is the brain's perception that, look, the nerves they're working overtime to try to sustain this activity. That may actually occur in Parkinson's as well. If you are less of a slacker and you work at things and you do a fitness program or you do some sustained exercise, you can improve these things. And we find that people can hit a higher level before they get the same barrier or fatigue limit. We find actually you can improve the blood supply to the muscle to a certain extent. You can change the number of oxidative enzymes in the muscle so that they work more efficiently. And if you do the right sort of program, you can actually make the muscle fiber bigger. And when it does that, the area of the muscle fiber is what generates force. So you don't need as many nerves firing to generate the same contraction. So you get the same work for less nerve effort, okay? All of these things are improved by exercise. So, not surprisingly, diseases that affect the peripheral nerves or the muscles or the connections between them can certainly aggravate fatigue, the fatigue of the type I've just been discussing. So just to give you a few examples, if it's the muscle that's affected, you may have heard of diseases like polymyositis or muscular dystrophy. These are primary diseases of the muscle, and this phenomenon occurs, the fatigue occurs more quickly, and they're more limited in what they can do. If it's the connection between the nerve and the muscle, this is something called myasthenia gravis. Weakness and profound fatigability are prominent aspects of this illness. If it's the nerve itself, same end result. There's a lot of different diseases that can affect the peripheral nerves, but one that maybe you've heard of that's not rare, Guillain-Barré syndrome, also called acute polyneuritis. So all of those aggravate the type of fatigue I've been discussing. Now, we're not quite sure what these peripheral examples really tell us about central causes of fatigue. And it's certainly true that diseases of the central nervous system can have quite profound fatigue as well. And I'm going to discuss two in a bit of detail. Parkinson's, of course, and MS or multiple sclerosis. Those are the main two conditions that I really see in my practice. In a lot of cases, we know it's not due to lactic acid buildup or oxidative enzymes in the muscles because a lot of these folks are so severely disabled they can't generate enough muscle activity to build up lactic acid. Now, it is possible, though, that excessive activity, as I mentioned before, could contribute to what they perceive as being tired. In Parkinson's, the electrical potential that's triggered when we put a magnet over the motor area of the brain actually is excessive. Probably that's a compensatory mechanism. So there's one area where excessive firing of nerves is taking place, and that may have something to do with the central fatigue that occurs in Parkinson's. Let's talk a little bit about multiple sclerosis. Most people have an image of MS being things like weak limbs, double vision or visual problems, bladder difficulty, possibility of things like wheelchairs. And that certainly can occur in perhaps half the people who have MS. But about 85% of people with MS have profound fatigue. And it doesn't correlate all that well with the physical disability. when they actually look at why do people in MS go on disability, and a good number of them don't, but eventually this happens to a fairly large proportion of them, it's usually not because they're in a wheelchair or that they've got double vision or something like that. There are ways around that. It's the fatigue that most leads to loss of ability to be productive and to stay in the workforce. And to a certain extent, sometimes cognitive difficulty as well. That occurs probably in about 30 to 40% of people with MS. So what happens in MS? Might this instruct us on why people with Parkinson's get fatigue? Well, probably not a whole lot. So the main disease process in MS is that the immune system attacks the central nerves. The insulation around the nerves called myelin is affected and stripped off. And this disruption of the nerve fibers interrupts the nerve impulses. When you have to send repeated impulses down the nerve, it poops out and fatigues. Anything that makes your body temperature a little higher, that can also suddenly cause nerve conduction block and more symptoms and more fatigue. Might that happen in Parkinson's? Well, not a whole lot. There are a couple of similarities. The excessive activity I already talked about with the transcranial magnetic stimulation experiments. There is a little bit of inflammation that possibly occurs in Parkinson's. This is a bit controversial. It's not been corroborated by all studies, but that may be one contributor of what's going on in the brain and contributing to fatigue. Probably the biggest similarity between the two, though, is this. It just doesn't get any respect. I think it's a separate phenomenon, probably, but it's harder to measure. It's so ubiquitous, people tend to shrug it off. But when we look at what surveys have shown, it's one of the real things that limits what people with Parkinson's can do from day to day. So as I mentioned before, it was first mentioned in the literature in 1967. There weren't actually papers dedicated to fatigue and Parkinson's until 1993. I think it's fair to say it's probably not mainly a peripheral nervous system problem, but a central nervous system problem. But other factors can contribute. So, sleep disturbance, very common in Parkinson's. Depression, again, very common. We'll go over these in a little more detail. Often you're taking medications, and potential side effects include things to aggravate your fatigue. And a lack of exercise for a lot of reasons. Now, these may not be the prime causes of your fatigue, but they sure as heck can contribute. In a fairly large review by Friedman in 2007, he summarized the studies that had been done up to that point. And he found that fatigue was occurring anywhere from 33 to 58% of the Parkinson patients who took the survey. Just a little over a half, 56% said, when I get it, it's persistent, it's there all the time, all my waking hours. 44% said it was something that came and went. A third of them rated it actually as their most severe symptom day to day. And 58% said it wasn't that necessarily, but they rated it amongst the top 3 problems for them. So again, part of the problem, as I mentioned before, is how do we define it? There are a number of fatigue scales that are out there, but they haven't been specifically validated in the context of Parkinson's disease. One that I came across in my reading is called the MFI, for Multidimensional Fatigue Inventory. And as they tend to do in studies, they try to break it down so we can tease out the various components. And they use 5 subparts in this inventory, and you can see them there: general fatigue, physical fatigue, mental fatigue, reduced physical activity, and reduced motivation. So a fellow by the name of Zenzola used this inventory in 19 people who had Parkinson's, and he also used 19 normal controls. He included 6 amongst the controls who actually had other neurologic diseases. And what he found, there was no correlation whatsoever with how old they were, the sex of the subjects, or whether they happened to have sleep disturbances as well. So suggesting that sleep, although it may be a contributor, wasn't a big factor in this group. Some of the aspects of the MFI inventory correlated quite well with depression. So that was general fatigue, reduced motivation, mental fatigue, suggesting that an underlying depression along with the Parkinson's contributed to some of the fatigue these folks were experiencing. The other 2 aspects, physical fatigue and reduced physical activity, didn't correlate at all with depression. And it appears that levodopa actually can help only these 2 aspects of the 5 components. A study in 1993 by Van Halen, a little larger study. This was 19 subjects with Parkinson's, and he excluded people who had depression because he didn't want the confounding factor of that contributing to the fatigue they reported. And he had some normal controls as well, 70 some of them. He found a high prevalence of sleep disturbance in Parkinson's. Many in both groups complained of excessive daytime sleepiness. He also found that fatigue didn't have the diurnal variation that we typically see. So by way of explanation, diurnal rhythms refer to the fluctuation throughout the day that we all experience, sort of our up times and our down times. And most of us are drowsier sort of shortly after lunch. If you want to take a nap, the urge is probably greatest shortly after lunch, regardless of what you had for lunch. And we're generally at our perkiest in the morning, and then we tail off again late in the evening. Those are called normal diurnal rhythms. They're driven by our brain. And they didn't find this diurnal rhythm in his group. So he thought, although there was a high incidence of sleep disturbance, he thought it was unlikely that that was the main contributor to fatigue in people with Parkinson's. The other thing that sort of discouraged him from blaming it all on sleep is just this subjective impression of the people who answered the survey. They said, you know, it just feels different. You know, I do have excessive need for sleep, but this is a different beast. Friedman, in '93, surveyed 58 people with Parkinson's, 58 normal controls. This time he didn't factor out or exclude people with depression, but he did exclude people who had any hint of dementia. Again, the reason because that can have fatigue associated with it. He found some correlation between depression and fatigue, but it wasn't striking, and there certainly were a fair number of his subjects who had no depression whatsoever and were still tired. He again found no correlation whatsoever with the severity of the Parkinson's, particularly the motor severity. Another study that adds a little bit of insight into this problem in Parkinson's, the L-DOPA trial. So this was a trial that was put up to look at levodopa treatment in people who were fairly early in their disease, had not been on a lot of other medication, and seeing what happened to these people over time. They were not on treatment already. They had no depression or dementia. And it was actually the first study that showed that levodopa can actually improve survival in people with Parkinson's. It also showed that early treatment didn't lead to more prominent complications that we associate with levodopa treatment. And with regard to fatigue, it said it was present in a third of these people, even though it was very early in their disease course. So again, it's something different from just the motor problems that occur in Parkinson's. And other studies pretty much agree with this point. It doesn't correlate very well with the motor severity, the trouble you have with movement. It can be seen early, even before there are any obvious motor signs. Friedman, the fellow who had the 58 Parkinson's subjects in his trial, has followed that group of people over time. And he reported on what had happened to them over 9 years. And here I can say something that's a little bit encouraging. Although the fatigue didn't go away generally, it really did not progress very much, certainly not to the same extent that their movement problems did. So it can occur early, kind of follows its own time course, quite separate from what's happening with movement. So let's try to get practical. We may not know the basic mechanism, but what can we do about it? Well, these may not be the sole cause, but I think you should try to optimize all these other factors. That only makes common sense, doesn't it? So sleep disturbance, depression, taking a close look at your medications, and maybe doing something about the lack of exercise that you've meant to do for a long time but haven't gotten around to. In addition, it's worth talking to your general practitioner about your general health. And it's very easy when you have a chronic illness to assume, well, gee, that's the explanation for all the problems you're having. Unfortunately, it is possible to have more than one condition. So it's worth sitting down and getting a general history and physical, making sure there's nothing else going on. In particular, common conditions, maybe these occur a little more often in people with Parkinson's. Obstructive sleep apnea, really common, contributes to daytime fatigue. Anemia and thyroid problems, I don't think they're more common in Parkinson's, but they're not uncommon at all. And they'll certainly aggravate your fatigue. Let's talk a little bit about the sleep disturbance that occurs in Parkinson's. It's very common, as all the studies have shown. It turns out, though, there's a lot of different things that can contribute. So one prominent one, at least for some people, is trouble getting to sleep in the first place. For some of us, it's getting our mind to relax. Don't know that that's any more severe in people with Parkinson's. If you've got Parkinson's, though, there's the other added aggravation of trying to get comfortable in bed. Almost all of us move around a little bit, change our position, try to find a comfortable place before we can get drowsy enough to drift off to sleep. If it's hard to turn over, that becomes a real challenge. If all of a sudden that intrusive tremor is rubbing against the sheets and here's this background noise, again, it's pretty darn hard to get to sleep. So what can you do about it? Sometimes a bedtime dose of levodopa or one of the agonists like Mirapex or Requip can help. For the tremor, you might get in the habit of sticking your hand in your pocket or under your seat. Silk or satin sheets and pajamas, I'm told, can be a big help and add a little luxury to your life. But the idea is something that's slippery, it's easier to turn over, there's less friction as you're trying to turn over and get comfortable in bed. A lot of people have restless leg syndrome. You'd think it was half the population if you listened to pharmaceutical ads on American TV, but it is a common condition. Probably 3, 4, 5% of the population. And I think it's probably a little more common in people who have Parkinson's disease. It can certainly keep them up for a good deal of time into the night. And there are some things that we can do about it. So the dopamine agonist Mirapex and Requip can be very effective in treating it. Clonazepam and gabapentin are two other drugs that often help with restless leg symptoms. Sleep myoclonus. This is a phenomenon where you get muscle twitches, sometimes called sleep startles. A little bit as you're drifting off to sleep is a very normal phenomenon. If you have it prominently, though, it can intrude. Just as you're getting ready to fall asleep, all of a sudden there's this jerk and you're wide awake again. And there are some medications that will help that, or at least sometimes they will help. So drugs like amitriptyline, clonazepam, yet again, and baclofen can all help if this is really a big problem for you. Muscle cramps. Again, you don't have to have Parkinson's to get muscle cramps, but there seems to be a higher incidence of this problem in people who have Parkinson's. Stretching before you go to bed can help. A little regular exercise in the daytime can help. Once in a while, a calcium or magnesium supplement will help. And again, the drug baclofen can help if it's a big problem for you. An overactive bladder. And again, there's a higher incidence of this occurring in people who have Parkinson's. Their bladder is sending messages to them before it's as full as it used to be, hence more trips to the bathroom. got to get out of bed, hard to get back to sleep again. So probably the most important thing is watching your fluid intake, particularly what you have from supper time on. I'm going to say some positive things about coffee a little later, but don't have too much coffee again from supper time on, or you'll be visiting the bathroom more frequently. And if all else fails, sometimes medications can help. So the drugs Detrol, oxybutynin, and desmopressin will often help people. Depression. Now, depression can cause a lot of different things. There is a higher incidence of this in Parkinson's, as I mentioned before, and often our sleep cycles are affected by depression. Some people find they sleep less. More often, they'll sleep more. In particular, though, a really common and often early sign in depression is waking up earlier in the morning. I don't mean the morning, really. I mean like 4 in the morning, 3 in the morning, and not being able to get back to sleep. And often they just don't know why that's occurring. That can be a clue that perhaps depression has intervened. So again, there are various medications that can help that, or counseling, or a combination. Dreaming is often excessive in Parkinson's. And unfortunately, our medications can aggravate this problem. If they're to the point that they're waking you up or giving you frightening nights, then it becomes a problem. So watching the relationship between your Parkinson pills and your dreaming tendency can help. I mentioned maybe taking a bedtime dose if you have trouble turning over and getting comfortable in bed. If that's not an issue for you, the problem instead is excessive dreaming or nightmares, you probably want to be skipping the bedtime dose or at least minimizing what you take in the evening, because that dose in particular contributes to the nightmares. If it's still occurring despite that, or you simply can't lower the doses because you're so immobile otherwise, then drugs like quetiapine or clozapine can help in that regard. And something that's sort of all the rage in the neurologic literature in the last 5 to 10 years is this condition called the REM Behavior Disorder. And it's a common disorder, and it's commoner yet in people with Parkinson's. So somewhere between 30 to 50% of people with Parkinson's get the REM behavior disorder. It can even antedate the illness. The Parkinson-like syndromes also are prone to this problem. So REM, as you probably recall, refers to rapid eye movements. It turns out in sleep that we've got 4 non-REM stages. You go progressively deeper and get more restful and peaceful sleep. And then there's also this other interloper called REM. And in REM sleep, we're basically immobile other than the fact that we're breathing and our eyes are moving rapidly. And if you wake people up in the middle of REM sleep, they'll usually tell you they're in the middle of a dream. So we think the eye movements have to do with the dream that they're experiencing. That's normal REM sleep. In people with the REM behavior disorder, they become more active. So their eyes are moving, but chances are so are their arms or their legs. They may be suddenly pushing their spouse. They may be suddenly whacking the bedstand. Occasionally, this is a big problem. People fall out of bed, they bruise their hand, they bruise their husband or wife, unintentionally, of course. And they're obviously less rested come morning. Occasionally, talking in your sleep will occur with this as well. So again, it occurs in 30 to 50%. Men seem to be a little more prone to this. And what can be done about it? Well, separate beds are one thing. You can also avoid aggravators. Alcohol seems to aggravate this symptom, and so can particular antidepressants called serotonin selective reuptake inhibitors or tricyclic drugs. Drugs that seem to help, clonazepam in fairly low doses, and melatonin, which is actually a brain hormone that's active in setting our diurnal cycles and helping us to sleep. The data is a little foggier when it comes to this one, but Mirapex, one of the dopamine agonists, probably helps REM behavior disorder, at least in some individuals, in modest doses. Coming back to depression. So it can intrude on sleep. It can also mess up your day, of course. And most of us think of depression as being persistently sad, and in some folks it is. But it isn't always. People can have what we call a masked depression, not even be aware that their feelings are down or they're sad much of the time or tearful. The other thing that sort of delays this being thought of, recognized, and treated is the fact that, sadness is normal. And it's only if it becomes persistent, going on a long period of time with few breaks from it, that it becomes a problem. Probably people with Parkinson's are more prone to it because chemically the illness sets them up for it. So when we become depressed, there's abnormal activity in the part of our brain called the limbic system. And it turns out that 3 amine chemicals are important in setting sort of our mood underlying all of this. And one of the 3 is dopamine, and the other 2 are serotonin and noradrenaline. So if you're low on dopamine because you've got Parkinson's, it's like you're chemically predisposed or more vulnerable to slipping into a depression than if you didn't have it. That's not to say that life circumstances can't be a factor in developing depression as well, but you're more likely to just have this kind of an abnormal, maladaptive reaction. I'd like to say a few words about exercise, mainly because it's easier to say the words than to do it. The literature is finally coming around to the utility of exercise, though, and that's true for all of us. It's true for many neurologic diseases, and it's true for Parkinson's as well. It's amazing how quickly a period of immobility makes people weaker and tireder. We see that when people come into the hospital and, say, are off their feet for 3 days to get a knee or a hip done or something. They lose muscle bulk, they're weaker, their walking isn't the same. Gosh, if you add to the mix, they're coping with Parkinson's as well, it makes it a whole lot worse. So you don't want to add deconditioning and the whole gamut of problems that we talked about earlier, the problems with the peripheral nervous system, to the mix, okay? Unfortunately, there's not a lot of data on exercise in Parkinson's specifically for the problem of fatigue. I can tell you, though, that there are short-term controlled studies that have shown improvement in things like muscle strength, gait, quality of life indices, and if you stick with it long enough, cardiovascular fitness. I'm not aware, though, that fatigue has been specifically studied. But hey, some things are just so sensible, you should act on common sense rather than waiting for all the data to come in. Like global warming in the States. Eh? There was one study, interestingly, that showed that exercise could improve that abnormal motor evoked potential, the one when I was talking about the magnet held over the motor cortex. That increase in activity moves back towards a more normal level in people exercising. Just before we talk about the medications, a couple of other points about exercise. It's tougher when you've got a neurologic disease. It's physically more demanding on you. It's harder to sustain because you're coping with fatigue. There's the issues of falls and all these other things. But nevertheless, if you persist, you can see these gains. You're going to have to set yourself more realistic goals. I suggest you try exercising with someone who's in the same boat as you, so you're not dealing with someone who can run twice as fast and is improving sort of at twice the rate. You're setting yourself up for disappointment if you do that. But do get out and do something. So medications. In the clinic, we're quite liberal at throwing these around. It's important to remember, though, that a lot of these can actually aggravate the problem of fatigue. So some of the obvious culprits, drugs that are anti-anxiety or tranquilizers, sleeping medications, if it's a fairly long-acting drug or a fairly high dose, can make you tireder come morning. Some antidepressants, some painkillers in big doses. Tylenol is pretty safe. Ironically, the drugs that can help your mobility, the dopamine-boosting drugs, levodopa and the agonists, will occasionally actually aggravate fatigue, which is a real source of frustration. In particular, it's the agonists where it seems to occur in about 15%. And sometimes just besides feeling tired, people will have sudden sleep attacks. Levodopa can do the same thing, not usually as profoundly, and it's probably 10% or less who report that. So, are there other things that we can do sort of approaching fatigue? Well, there are a few drugs that occasionally help a little bit. One of the older Parkinson treating medications, amantadine, also known as Simitrel, also seems to help fatigue occasionally. Okay? It also helps fatigue in MS, which is kind of a connection. Methylphenidate, which is Ritalin, or dextroamphetamine, which is dexedrine, occasionally help. Again, you don't want to be overusing these medications. One of the problems with them is that they can help you for a few hours and there's sort of the crash or the rebound. So you want to be judicious if you try these, and you don't want to persist with it unless you're getting a pretty reasonable response. And something that appealed to me, I respond positively to things that tell me my habits are okay. So I'm hooked on coffee. I probably drink more coffee than I should. For quite a while, we've known that coffee actually has some protective effect in Parkinson's. And several studies have shown this, that having caffeine or coffee throughout your life slightly reduces the incidence of developing Parkinson's. Probably more likely what it does is delays the onset a bit rather than stops you from getting it. But now we're seeing some data that it also can do positive things even after you have Parkinson's. So this is a study out of Toronto, actually, and they didn't have the pleasure of drinking the coffee. They used caffeine tablets. It was a controlled study, and they had 400 milligrams of caffeine per day, which, depending on how strong your coffee is roughly the equivalent of 3 or 4 cups per day. And they showed that actually some of the motor manifestations, the mobility problems in Parkinson's, improved with caffeine. And although it didn't reach statistical significance, when you actually look at it graphed out, probably the most positive result of the study of all, was that fatigue was improved. A word of caution, though, like most good things in life, you have to do it in moderation. And just as with the stimulant drugs that I mentioned, a little too much, and then you're dealing with kind of the rebound crash thereafter, and then you get in a vicious cycle of chasing it with another cup, and so on and so on. You don't want to be doing it too much at night or it'll keep you awake. And you also pay the price of having to visit the toilet more often if you are drinking too much coffee. So, by way of summary, what can you do in a practical sense until we kind of solve the problem of what actually causes the central fatigue in Parkinson's? It seems to be something different from just the dopamine and the motor problem. But that's not to say that you can't do anything. So you should get a general assessment from your family doctor or internist, a physical, lab tests, rule out the additional problems that I talked about. And even though Parkinson's fatigue may be probably some central beast that we've yet to really fully define and understand, we'll call that the camel. That's not to say that you can't remove the straws that are bending the camel's back. And those straws are the things we've just been talking about. So watch out for medications, kind of optimize your medications. Look out for sleep disturbance. Do something about the lack of exercise. Consider the possibility that depression might be contributing. And sometimes, even if you don't feel particularly depressed much of the time, if you have some of the other symptoms that can coexist, it can be worth a trial of just trying medication for a while and see if it helps. And occasionally consider a trial of supplemental medications that may help fatigue, including coffee in moderation. And that's all that I have. I'm open to questions.
Hi, I'm William Gard from Stratford. Is this on?
All right.
Is it on? I can't tell. I've had Parkinson for 9 years now, and I have REM sleep disorder. But besides that, I started exercising when I was first diagnosed with a yoga teacher, and he was also a fitness instructor and got me bike riding and doing some other exercises to build muscle strength. And he would say to me that you have to expend energy to get energy, and I couldn't understand that because I was...
I'm sorry, I missed that last sentence.
You have to expend energy to get energy.
Okay.
And I was a couch potato. I was not one for sports or activity. But I found that after exercise, I would be tired for 20, 30 minutes, but then I would be energetic for the balance of the day. And I also found that yoga improved my balance scores when they do the test where they pull you backwards, and improved my general muscle tone and my general responsiveness of my body to the medication. So I firmly believe that exercise is very important.
How long did it take before you were starting to see these improvements?
I'm sorry?
How long did it take before you were starting to see improvements?
I would say I was starting to see improvements within 6, 8, 9 months.
Okay. Well, thank you for sharing that. And I think it's certainly true, no pain, no gain. Although exercise doesn't have to be to the point of being painful, but you certainly have to expend energy. And the phenomenon of actually feeling worse afterwards, that happens to everybody. It's more of a challenge when you've got Parkinson's. So you build up gradually. At least for most people, that's what you need to do. You do a little bit, you take a break, you do a little bit more, and you stick at it. Okay.
Is there any other questions? I can bring the microphone to whomever if there's other questions.
We
for
can
Dr.
race.
Paulseth. What? Oh, Bev and I, it's race. Okay. Any other questions? Oh, right over here. I won, Bev.
If you're not a coffee drinker and you want to get caffeine into your system, is there a pill for that?
Yes, actually, I guess you can do that. Consider tea, though. It's probably a little bit harder to know what your intake is because it varies so much with how strong your tea is, but tea also provides you with caffeine. Coca-Cola has caffeine. I think Mountain Dew does, but I'm not positive of that one. And I wouldn't advise these ones, but energy drinks like Red Bull and so on, the problem with that is it's a mega dose. And if you take a big dose, you know, you get a buzz for a bit and then you crash. That's not a sustainable way to go about it.
Hi, Phil Thomas from New Hamburg, former patient of yours in Hamilton. I found I've had Parkinson's for 16 years now, and I have other health complications, and I've always liked exercising, and but the last few months I found it increasingly difficult to schedule it. I have medical appointments practically every day, and some fatigue, and just everything gets so complicated that it's just hard to schedule exercise as much as I'd like to do more than I've done the last few months. I've really fallen off the wagon the last few months just because of just sheer complication of life.
Well, that's not to say that you can't get back at it, though. And you know, when you have specific limitations and your mobility is quite impaired, it probably behooves you to sit down with a physiotherapist or a kinesiologist and kind of get something tailored to your restrictions and abilities. If nothing else, you can certainly work on stretching. And another thing that I hear very positive things about, even in people who seem to have terrible balance, some of them are great on bicycles. Amazing. But
yeah, I ride a tricycle with balance problems. Yeah.
Okay.
Yeah.
We have a question here.
Bless you for giving me permission to drink good coffee. I've done it in spite for years. This question doesn't particularly pertain to sleep disturbances, but what I'm wondering about is temperature control. I have heard several people with Parkinson's complain that they will be extremely cool. It ends up being the thermostat fight. The Parkinson person wants to turn the heat up. and the person without Parkinson's is taking off as many clothes as they can and remain decent. Is that part of Parkinson's, or is this another phenomenon?
No, I think that's a very common occurrence in Parkinson's. And it seems to be that it can be either extreme, though. So it's like the thermostat is sluggish. Part of that relates to the autonomic nervous system that's often affected in Parkinson's. So that affects things like our ability to adjust to changes in temperature, dilating the blood vessels under the skin, sweating, and so forth. Those things that sometimes they're overactive, drenching sweats. Other times you're overheated and they're not kicking in. I couldn't tell you just the frequency of it, but I think it's a pretty common occurrence. I don't know an antidote.
Oh, I have a question about exercise. Does it need to be strengthening exercise? Does it need to be cardiovascular? Any direction you have that way for us?
I think anything is helpful. Most people over the last 20 years or so have probably emphasized particularly walking and stretching. But, I think a little bit of light weights are good as well. And a lot of people don't really worry or consider cardiovascular, but there's no reason that you can't do that. I think everybody probably should have their own sort of personal goals, and even if you do most of it on your own or with a buddy, it's probably worth having some input at some point, say from a physiotherapist or a kinesiologist. In Hamilton, we have the resource of a well-organized physiotherapy-run exercise group that meets at St. Peter's Hospital twice a week. So often getting to be part of a group can get you motivated. But again, I'm rambling. I think anything is okay. There was a question at the back.
We have a question right here.
Hi, Brenda Walden from St. Thomas. I've just been diagnosed with Parkinson's, and I've noticed in the last few months that I'm getting a tingly, burning sensation from my shoulders down to below my chest, and it's keeping me up at night. Is this a reflection of Parkinson's? Have you heard of this before? Is it like Restless Leg Syndrome? Is it just on one side? No, it's the whole top, right and left.
And you only get it at that time?
At night, and it keeps me up at night.
Okay. Do you have wearing off if your medication, if you're overdue for the next dose? Do you feel that way?
No, I have bipolar spectrum disorder as well. I take a lot of medication for that, but it's not wearing off.
Okay.
It's happening at about 1 o'clock, 2 o'clock in the morning.
Okay. Well, a couple of possibilities. Wearing off, when the dopamine levels drop, the most profound thing for most people is that they slow down, they shake more, it's harder to walk, maybe they freeze more. But there's a lot of other things that can occur, and strange sensory experiences like pain or burning or tingling can be part of that. Usually if you're late enough in the daytime, you'll experience some daytime episodes as well that will sort of give us a clue that, hey, this is a wearing off phenomenon. But occurring in the middle of the night, it is possible it's related to that, and perhaps taking a bedtime dose of a longer-acting drug like the controlled-release levodopa or an agonist like Mirapex might help. If it's really just sort of neck down, it's probably worth making sure that you don't also have a problem with cervical disc disease or arthritis in your neck and so on. So start with your general doctor as well.
Okay, thank you.
We have time after Carol. We have time probably for about one more question.
Got one right here.
Sorry. Hello? I'll be brief. Hello? I'd just like to recommend seated yoga or gentle yoga, and also seated Tai Chi is even available in Little Clinton. So there are lots of, just for starting, if you haven't done any exercising for balance and stretching.
Thank you. I hear a lot of positive things about yoga and Tai Chi. Yeah.
Hello? Hi, I have a question over here. Hi. My sister's just been diagnosed with Parkinson's, and I was wondering, there's no one in her family that has Parkinson's that any of us are aware of,
So is it hereditary, or is it just coming from somewhere else?
It's hard to give an answer that fits all. The majority of cases of Parkinson's seem to occur out of the blue. There isn't a strong family history in most situations, but about 10% seem to be fairly strongly clustering in families. And in the last 15 years or so, sort of our knowledge about what genes underlie this genetic subset is growing. And some people where it seems to be sporadic, there can be a gene like the one that Dr. Jog referred to earlier, LARC2, sometimes appears to be out of the blue, and yet it is actually genetic. So to answer your question, you'd probably have to look very closely at all your distant relatives. But more often than not, it seems to be out of the blue, sporadic, and not running in the family.
Hello? Hello? Is that on? Yep.
Hi. You said that caffeine fights fatigue, but what about tremors?
I'm sorry.
She was just saying that caffeine fights fatigue, but what about tremors? Does caffeine do anything for tremors?
No. In fact, if you overdo it, you can add a little bit of an action tremor to your rest tremor.
So it potentially can aggravate it?
Yeah, but that usually requires a fairly hefty dose.
Okay. Dr. Paulseth is going to be staying. I'm sorry, you are staying for lunch, is that correct, Dr.
No, I'm
Paulseth?
afraid I can't.
So he's going to be leaving immediately, but I'm going to invite Kathleen Needles to say thank you to Dr. Paulseth.